When this session was being devised, I don't think we'd anticipated that Matt Hancock was going to answer the question yesterday. How far are we willing to go? Well, apparently no variation at all. We're going to have the same everywhere, but I'll leave that to our commissioning colleagues to have that interesting discussion with him over the coming months. There's always been variation from time immemorial. In the Greeks and the Romans, there was variation. The first time it was probably properly documented was probably Alison Glover, which is with all respect to anybody who ever mentioned some variation or identified it before the 1830s. And he, as you may know, it's very famous, pointed out the tonsillectomy rate for elementary school children from the education system. The health system didn't have the data. And he showed that the rates of tonsillectomy in children, Margate, 8 times that of Ramsgate next door, fairly similar socioeconomically, Enfield 6 times that of Wood Green, Bath 5 for Bristol, and so on. Extraordinary differences. And some light was shone on this by this, oh, okay, we're missing bits. This lovely study from New York that came out at about the same time, and they took a bunch of 1,000 11-year-olds, and they found that 60% had had their tonsils removed. And they took the other 40% and got them reviewed by ENT, clinicians, otolaryngologists, and they reckoned that almost half of those needed their tonsils removed. And then they took the final 20% and they took them to another bunch of ENT surgeons. And hey presto, they thought half of them should have their tonsils removed. And they took them. And by the end, after 3 reviews, there was virtually no child would have had their tonsils. And what this showed was, what we came on to recognize through the work of Jack Wenberg and others at Dartmouth in the 1970s, was that there is clinical uncertainty, professional uncertainty on many aspects of healthcare as to what are the appropriate indications, when should interventions be used, and you get these variations, and Jack and colleagues, this was just one of the early papers in the 1970s, and that work continued through particularly the 1980s and 90s, and culminated in recent years with these sorts of atlases of variation you're probably aware of in many countries, just showing how much variation mostly focused on utilization rather than on outcomes. And that is sort of where we had got to. Now, the interpretation of some of this variation is very straightforward, in that we know in the differences where we'd want to live, what is good and what is bad. So here's work from the renal registry in this country on renal replacement patients, 1-year survival after their transplants, and as you can see in all the units across the country, there is some variation, actually rather little, but there is some, and there are 1 or 2 units that are on the whole better than expected in terms of survival. I don't think there are any that are worse than the English average. And it can look also much more easily done, because we don't have much outcome data in the health service, on processes. So we can define, or others can, that mothers expecting preterm delivery ought to have antenatal steroids to reduce the risk of respiratory distress syndrome in their neonates. And it was agreed, professionally informed by the scientific evidence, that we should be aiming for about 86%. Not 100%, because there are some women it's contraindicated. And there you can see, this is 2011, it's improved since then, I should say, but then it's just to show the example of process measures, and you had these maternity units down here where you would not want to be having a preterm delivery with only 60% or so of women getting what is known to be a effective treatment. And we can look at another thing where there is good scientific evidence from randomized trials and whatever, that on the whole, hip replacements, you're better to have them cemented rather than not cemented. They last longer and so on, outcomes are better. But look at this, in 2013-14, this was from the start of the Getting It Right First Time, the GIRFT project from Tim Briggs, and again, all the different orthopedic units across the country, and some of them are indeed cementing all the hips. Perhaps it doesn't have to aim for all, but the vast majority. But you've got some down here where they're virtually never cementing the hips. I know which hospital I would want to go to for my hip replacement. The other thing that hasn't been looked at so much, but again is straightforward to interpret as unwarranted, is variation in costs. And this relates very much to what Ash Shah was saying this morning in some of the international work. On the whole, those of us, and I take some of the blame, who worked on variations from the 1980s through, we focused almost entirely, in fact entirely, on variation in clinical effectiveness outcomes, because that is what we thought was the issue, that there was unnecessary or inappropriate, or perhaps actually under treatment as well, and that was the main driver. As Ash showed this morning, it's not actually about quantity, it's the other part of the equation, it's the cost, or price as he used it this morning in the American context. This was some work we did looking at memory clinics where you get sent if you've got cognitive impairment, where we can determine whether somebody's now could be diagnosed with dementia and appropriate interventions. And this is the cost for that first referral and the first 6 months of clinical management. And this is data from 2015, system level costing, bottom-up costing, and even if we exclude the outliers, although all the data was checked, that this really was confirmed that this was £5,000, but there we are. But even if we ignore that and look at the bulk of the ones, 84%, it still varied sixfold for the same process of care. And I can tell you, because we followed up all these patients, the outcomes were identical. So this is not that you're getting more effectiveness from the spending more money. But you've got now, when we got this, I asked around a lot of people, a lot of health economists, what did they think of this? Were they surprised? Most people were surprised at the extent. I said, is this typical? Because it turns out there is no comparable data on the NHS on the variation in the cost of production of care. What we've got is reference costs, which are actually simply prices, more or less pulled out of the air. This is absolutely extraordinary. And when we worry, those of us who worked in the sort of the variation lobby industry, we worried about outcomes varying 20%, 40%, 60%. This is 600%. So in a sense, the focus needs to be as well on the costs. Okay, there is some sort of indication of variation in costs. This is from GIRFT as well, from the ENT program published recently. And you can see day surgery. We know that the outcomes of day surgery for ENT elective procedures is just the same as for inpatients. And yet you've got some hospitals where all the procedures are being done as day cases and at the other end down at 30%. And you can sort of, obviously, there is cost benefits to be got by shifting to more day surgery. Now, yesterday, Nigel used this slide. In a sense, what I've been talking about is the variation down here, where we know what should be done, and there is pretty good agreement amongst clinicians, managers, politicians, it ought to be done. But of course, most of healthcare isn't in that segment, it's up here. What are we going to do about that, and why? What are the reasons for that? Because if we don't understand the reasons, we don't know what we should be doing. And answering that question about, is this variation a good thing, a bad thing? How much are we willing to accept, assuming you could do anything about it? Another suggestion is there are 4 reasons for variation, aside from all that unwarranted variation with a good scientific basis. The first is there's a lack of consensus. We don't actually know what we should be doing. We're waiting for the research evidence to emerge. There's clinical uncertainty, and that's a huge amount of what we do in healthcare. The second is, and this relates back to some of the things talked about earlier in this meeting, is if we want to encourage local creativity, social entrepreneurship, innovation, inevitably there will be greater variation. Are we going to tolerate that? Because you can't have both. You can't have local innovation and say we mustn't have we mustn't have it because there's variation. That's got to be reconciled. 2 very quick examples. One of the commonest problems, as you know, elderly people falling rapid response services have been introduced all over the country in different places, locally in different ways. This is a great example from Nottingham, a combination of the Ambulance Trust and the social care, social services in Nottingham. 14% of 999 calls, 14%, that's a huge number, are for elderly people who have fallen over at home. And when they started, half of them were picked up by the paramedics and taken to hospital, and they're in the queues in the ambulances outside A&E or on trolleys. They introduced a falls rapid response team, combining the paramedics, the social workers, and halved the number of people being taken to A&E. Another example, Dennis O'Rourke, integrating commissioner for mental health in Lambeth. He got together in 2013 all the relevant people involved in using mental health services in the community. They developed a thing called the Living Well Network, which isn't time to go into what it was, but it was absolutely bottom-up, local, with amazing results. It now supports 1,400 people a month, 40% reduction in referral to psychiatric services and so on, secondary care services, and taking the pressure off those very overburdened services. So there are some great things that can be done, but that's going to introduce variation. Are we going to tolerate it when we find that variation in the use of secondary mental health care or in the use of A&E is the result of that? There are 2 other of the 4, and the 2 colleagues are going to be talking about these. The first is that a lot of variation is a sort of legacy. It's also context of how things are provided in different areas. And much as we might wish that perhaps every ICS in the country had exactly the same formation of services and configuration and availability, that is not the case. They're all starting from different positions. So that's another source of variation. So what do we do about that? So local context and constraints. And then second, the final one is, and it comes very much back to the Matt Hancock's comments about IVF yesterday. Are we saying that local commissioners have all got to commission, in which case, the same way, in which case, why do we have local commissioners? We just have NHS England commissioning for everything and just telling everybody what to do. Because inevitably, if we want local responsibility for commissioning, people will commission in different ways and variation will result. So, with that background, Louella Vaughan is going to speak first on secondary care.
Thank you very much. I must say, I've been asked to talk about variation in secondary care in 8 minutes. And given that many people in the audience know a lot more about variation than I do, I sometimes think this is a slightly unfair task. It's like expecting 7. Well, there we go. I'm wasting my time with anecdote. What is it? At what point is variation acceptable or unacceptable? And I must say, this is quite a difficult topic. So there is undoubtedly quite substantial variation in the delivery of secondary care in England. So we'll talk about England. So these are the SHMI mortality rates, so the standardised hospital mortality index. If you're above the line, you're not doing as well as you should for your population. If you're below the line, you're doing really well. So there is substantial variation. The response to that at national level has been to find it, hunt it down and eliminate it. And these are all of the sorts of organisations which are involved in either standard setting, collecting data, or punishing those who deviate from the party line. I've tried to kind of group them across, but some of these organisations sit across both. Now, this is not to say that aspects of this endeavour are not entirely worthy, and in fact, it should and ought to be done. The best possible example of this one of the excellent examples of this is hip fracture. We know large amounts about hip fracture. We know whether your hip replacement, and along with this, other joint replacement, what you should do, what sort of joint is better, how much does your joint cost, what sort of approach should you use, how should your team be set up, how should your theatre run, day case, inpatient, what should your physio, OT, rehabilitation look like. There are multiple high quality studies which have been done on this, plus the lovely work of the National Hip Fracture Audit, which has demonstrated real benefits with reductions in mortality, reductions in length of stay as variation has been eliminated. So this is an excellent example of where variation should be hunted down and eliminated. There is no argument with this. A much more interesting example is around stroke. So stroke is a very defined clinical condition. You get a clot in the artery in your brain, which is something that happens in a second, in an instant. The patient can frequently, well, perhaps not the patient, but someone around you, the patient can tell you exactly when it happened. There are excellent high-quality studies done on the critical time intervention of thrombolysis, and there have also been large numbers of studies done around other aspects of care. So again, this is something where the evidence is very clear. And the excellent work done of the National Stroke Audit, hosted through the RCP and for a long time led by Tony Rudd, undoubtedly found that as processes of care got better and individual units got better over time. So this is the graph on the right. So this is the number of patients thrombolyzed over time. That's the volume, that's the number of patients they're seeing with thrombolysis. What you see is a lovely drop in mortality. This is a phenomenal outcome. Stroke patients in the UK did not do well, and now they do very well. Well, it's still, it's all relative, but substantially better because the mortality is still out around 20%. But substantial improvements in outcome. An observation of this excellent work was that the bigger your unit was and the more patients you thrombolyzed, the better your outcomes. And so the natural corollary of that was, if we consolidate the number of stroke units into a smaller number of units, therefore the outcomes will continue to improve. Unfortunately, this was not actually quite true. So they managed to get some improvement in mortality with the reconfiguration in London, but only in 90 days, not at the 30 days as might have been expected, as seen from the changes in the other graphs. And the outcomes in mortality were very slow to materialise elsewhere in England, including in Manchester, where there was no change for several years. And so this caused a lot of consternation. There was some excellent research done by Naomi Fulop, who is in the audience, and her other colleagues, including Steve Morris at UCL. And the finding was really interesting, which was that it's not actually just doing what you should be doing, it's the context in which it is done and the other peripheral things that sit around it. So it's all fine to say that you need to get your patient, if your patient is having stroke, you have to mobilise the ambulance and you have to get the patient there in a timely fashion, then you have to get them into the scanner. But the ways in which you do this are context specific and depend on what your starting point is like and how you manage the change process. And this is something that is known from business change. Half of all business change fails, and then after that, 25% of it doesn't stick, so actually 70% of all change doesn't work. So this was a very interesting kind of trade-off between the things that you should do are clearly known, but actually doing them at scale, doing them at pace, changing things, failed to make the improvements that were expected. And this was because it was around constraint in the change of setting. So this is a slightly more complex example. So as you all know, NHS England and NHS Improvement have been running a series of national programs about how to deliver care at the front door better. Through a whole series of initiatives. In fact, this goes back so long I couldn't even find the logos for some of the previous rounds of this. And it's basically based around, on this side this is the model hospital, so this is all the kind of stuff that you should be delivering as a kind of mosaic of services. And then on the other side we have some of the specific initiatives about what you should be doing at the front door. So you should have, you should have an SDEC, and which is same-day emergency care, which is basically it should have some acute ambulatory care, some acute surgical care. Ideally, it should have an acute frailty unit where the patients are rapidly seen and assessed and turned around. You should have GP streaming. So these are the sorts of things that you should have at your front door. Well, what is the evidence for this? Well, there is no evidence for ambulatory care. So this was a recent review published by Dan Lasserson, who is the Professor of Ambulatory Care at Birmingham. Basically no evidence. Pretty much everybody in the whole of the UK does it. I think 96% of acute trusts do ambulatory care. No evidence for it. GP streaming, hot off the press from my good friend Tom Hughes, who is the National SDEC lead, published in the BMJ this week. No real evidence for GP streaming either. And in fact, at my hospital, we found years ago that the nurses are much better at streaming than GPs. And then we're talking about who does there's two aspects to GP streaming. Who does the streaming and where are the patients streamed to? There was no evidence at our hospital for GPs doing the streaming or streaming into GP, and we got rid of it. And now we have to have it back again because the national evidence says so, despite the fact that our own local data said that it didn't work. And there is no evidence for this. Frailty CGA. The evidence for this is in inpatients, and there is an interesting thing about the contextualisation of comprehensive geriatric care in the inpatient setting. Is it the CGA itself, or is it what happens within the team and the circumstances in which the care is delivered? This is still not being clarified. Undoubtedly, CGA in the inpatient context helps get the patients home and keep them at home. Is it going to be the same if you try to do this in a busy front door unit with staff coming and going without the time taken to see the patient? Is there evidence for that? Well, as yet, there's not good evidence, and David or Tom Downs might care to correct me on that, but my understanding of that is that we are talking about taking something that is proven to work in one setting and transferring it nationally into every hospital in an untried setting. And this is the setting back here that we've shown that it doesn't work for patients who don't have complex frailty needs. Right. So we then looked at as some of you might be aware, I've been doing work on medical generalism for many years. And the hospital on the right, so these are both two small hospitals. So these complex diagrams are just basically flows of patients through various bits of the hospital. So this hospital tried to do all the things here, and the flows through the system look like this. So spaghetti. Another hospital, which is about exactly the same size and in kind of the same sort of area, didn't refuse to do any of it and just stuck with ED, bit of ambulatory care, and that was it, and that's all it did. And the interesting thing is that this produces complex streams and flows. I'm not an engineer, so I don't know how to analyse it, but you only have to look at this going, it's hard to have grip on this. How can you have grip from a bad management point of view, know what's going on in your process if you've got this? This is easy to manage, but this emerged because the ED and the AMU are at the other end of the hospital from each other. So you can't actually set your services up any other way. This one, they had a warren of units out the back. They moved their radiology department, and so they put all of these little things in all of the cupboardy spaces left over from the radiology department. But that's what they ended up with. And the really interesting thing is that when this hospital got rid of this, after we showed them this, they kind of went, oh, and they got rid of this, and they went from being an average performing trust on the 4-hour target to being one of the top 10 performing trusts on the 4-hour target. So they have stopped doing what has been prescribed, and their performance has improved. Right, so Nick has covered some of these, but I think it's just worth reiterating. One always has to think, how good is the evidence? Really, we're meant to be doing what the evidence says. If there is no evidence, don't do it. And frankly, physician consensus, I'm increasingly thinking is just not enough. That's a heretical thing to say. But I increasingly think for some things, as Nigel said, just because it's good in Luton doesn't mean everybody else has to do it. I think there's a very interesting issue of factory floor versus bespoke. Those processes which can be tailorised should ought to be tailorised, and processes around how you monitor, are aware of, monitor and eliminate variation are completely appropriate. But there's lots of things for which it's not appropriate. If we're talking about personalised care and it's bespoke, you can't tailorise it, you can't measure it, and it would be wrong to do so. As Nick has already pointed out, is what you've got, is it really genuinely variation, which it might be bad, and in fact actually being a black sheep, there's nothing wrong with being a black sheep sometimes, or are you a goat? So actually, how can you tell the difference between these two things? And just because it's a goat also doesn't mean it's a good if you want the wool. So actually thinking very hard about what you're seeing, variation or innovation or poor performance. And it comes back again to context, 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 context. Most of what you do in hospitals is context constrained. We are an environment where there is not enough of anything in secondary care most of the time. I'm really lucky, I work at Barts, we have lots of stuff. But most organisations are not that lucky. And so what you do the best that you can with what you have, which leads you to, if you were trying to get rid of variation, you were trying to have all the services the same, to get to there, I wouldn't start from here. Thank you.
On commissioning.
Thanks very much. So it's a hard act to follow. And what I want to do really is pick up from Louella's point about context and really think about how population health shapes context, and actually how, if we do what we're asked to do in the long-term plan and increasingly throughout all our health policy initiatives, respond to population health need, we are likely to necessarily drive more variation. I'm going to use a couple of examples, one from commissioning and one from primary care networks, to explore how that variation might emerge and how we might respond to it, and then just have a very quick reflection on how our responses to variation might shape our ability to maintain professional engagement in the changes that we want. So, just thinking about population health needs, we've got a long and fabulous history in England, in the UK, in the NHS, of needs assessment. I don't know how many of you remember those lovely round commissioning cycles. They were everywhere about 20 years ago. And point one is always population needs assessment. We have got a long history of joint strategic needs assessment across health and social care. And then coming down into the primary care sphere, about 20 years ago, there was a big movement about community-oriented primary care, which was absolutely about designing your general practice and primary care services, connecting them to your local population and addressing specifically local needs. And then I've included the little Rubik's Cube here, which has come out of the primary care home initiatives. The idea being that each subsection of the cube represents a population subgroup with a specific set of needs. And the narrative is that primary care homes should be designing the services that they deliver in order to meet the needs of those specific subgroups. So this has been an underlying logic of all that we've been doing for many years and continues to be so. So what I want to move on to now is an example from my own patch. I'm a GP in Greenwich, about commissioning specifically for variation. So the Royal Borough of Greenwich has just commissioned a new Startwell service, which is about health and well-being services for children and young people in the borough. And they specifically put out a tender or invited tenders to deliver 4 locality services shaped according to the specific population needs of the 4 localities that they defined in the borough, but also that had to address the overriding priorities of the borough as a whole. And they ended up commissioning these services from 3 different providers, so one of them is serving 2 of the areas. They said that you have to provide these core services. I won't read through them, that is the essential elements, but the tenders were assessed on their alliances with local voluntary sector groups, with the way that they were going to nuance their services to specifically address the particular needs of ethnic subgroups within the localities, etc. Very importantly, and this ties into what Matt Hancock, I think, was talking about yesterday, I want standard outcomes, but I'm not going to specify the way they are achieved. They have created a list of KPIs that apply to all the services that are standard across the borough. There's a very broad range. It's a large spreadsheet with several pages. It covers inputs, activity, reach into the local population, uptake of checks, links with other services, and various outputs and outcomes. Just a couple of exemplars. So an exemplar of a KPI for outputs is the percentage of eligible families registered with Healthy Start, and a few exemplars of the direct impacts they want to have from the services. So progress against goals in multiple domains. That means you look at where an individual, a family, a parent, or a child starts with a particular issue and set goals for how the services will help them to develop and improve. So issues around parenting skills, mental health, anger management, things like that. Percentage of mothers breastfeeding at 6 to 8 weeks, percentage smoking in parents, smoking cessation in parents. So a wide variety of aspirations and some real opportunities in this approach. So they have got a much increased focus on prevention than they had previously. They have identified a range of new priorities for adolescents. They have managed through this approach to preserve children's centres, which have been one of the great successes in the delivery of children's centres. In many areas, they're shutting down. This has enabled them to preserve them, so a lot to be said for it, but also a huge number of challenges. The organisations that are leading these services are not natural healthcare organisations and healthcare providers. They're now going to have to implement services, working with professionals from other sectors. There's a whole load of implementation challenges. There are challenges about quality improvement and assurance. There are challenges about coordinating. Each of the organisations that's running them is going to be working with 4 or 5 others. And then for the commissioners, actually challenges in monitoring whether they are achieving the outcomes that are set out in the contract. So what's going to happen if they don't? What's going to happen if they focus very much on the population subgroups that they've identified in a locality that they want to give particular attention to, but in doing so slip on some of the other outcomes? How long will we give them to kind of all level up? I'm going to come back to that question. I just want to park it, but I think it raises very interesting challenges about once you start to commission for population-defined variation, how far can we then go in the outcomes that we achieve? Oh, I seem to have lost a slide. That's interesting. So I was going to move on to primary care networks. So primary care networks formed across the country, and there is a national programme in place to do needs assessment at primary care network level. So we are creating the data to understand population health need for each of these networks. And PCNs are going to be invited to work out what the needs are in their local population and how they want to address them. These are 2 slides from my own borough. So we have 6 primary care networks. This is mine. It's called Riverview. And the 4th one down, and you'll see that we have a lower number of older people than the 2nd one down, which is Eltham, which is where the large majority of the very elderly are in my patch. So they do a load of home visiting, but we don't. And my PCN has a much, much bigger issue with drug and alcohol addiction, with mental health problems. The average life expectancy at birth is very different. So my patch has the lowest for the borough, a lot to do with suicide, drug and alcohol addiction, etc. So clearly my needs in my PCN, or the needs of the population in my PCN, are very different. So what are we going to do about that? Well, I think we have a number of different ways in which we can respond now as primary care networks, partly in how we recruit to new roles and therefore in the development of the services that are going to follow. So we've had discussions about whether we recruit paramedics who can do home visiting or mental health workers. We're going to recruit mental health workers, but The other patch will be recruiting paramedics and setting up a home visiting service. And a patch that has a very young and mobile and working population may well decide to start investing in digital technologies and creating more digital services. So these variations are going to start to creep in. And I think getting back to the discussion that we started to have yesterday, what will be tolerated? One answer may be nothing. But I think once you get down to these very local levels, we're used to a certain amount of variation. But what will happen if there's a difference in response time? If the Eltham patch has a 2-hour response time for home visits and mine has 5 or 6 hours? What will happen if differences in eligibility criteria emerge? What will happen if some services are present or absent in different parts of the borough? We're kind of used to this, but if this happens more and if it becomes more pronounced, is there going to be any kind of backlash about it? How far are we able to go? And then just a final thought. Coming back to what I said about what happens if the new services that people are going to bust a gut to set up don't deliver the kinds of outcomes that we want. All of them are going to take a huge amount of effort, of resources, of OD support, of professional time and input to develop them. The narratives that are rooted in population health need are very, very powerful with professionals. They are a good way of engaging people. But I think it's very important to note, and we've just seen this with the primary care contract, that actually there are other things that are really important as well, like getting your practice to survive and sustaining primary care. So there's going to be a variety of interests that are going to shape the services that are developed. But if we don't deliver a kind of adequate uniformity, and perhaps we start then imposing a kind of blueprint and saying, no, you've all got to do it like this, what you then risk is a kind of backlash, a disengagement, just participating at the margins from the professionals and just thinking, well, I put all my effort and soul into that. I'm just going to, do the bare minimum and carry on. So those are some of the things that we are likely to have to deal with, I think, as these very local services start to emerge.
Okay, open now for questions and comments on anything that's occurred to you from those talks. These were just some of the sorts of questions that we had imagined might be worth addressing. If unwarranted variation is not acceptable, we're all, I imagine, agreed on that. But how much warranted variation is acceptable? How should innovation and creativity be managed, regulated, actually positively encouraged, which Matt Hancock seemed to be saying yesterday that he would encourage local innovation if it increases variation? And are we making the best use of the variations that exist for quality improvement and service transformation? But that's not exclusive, that's just to stimulate thoughts. Anything you've heard about, and I can already see 1, 2, 3. So John, Andy, and then Peter.
John Appleby, Chief Economist at Nuffield. Thanks, Nick. I've written down about 24 points and one question. Is that okay? No? Okay. All right, just a couple of things. I think we just got to bear in mind that reducing or even eliminating inequalities is not a costless thing. It's maybe a massively desirable thing to do, and we can be really offended at the sort of variations you've pointed out, Nick. And virtually everywhere you look in healthcare, there is some variation, including the reference costs, by the way, even allowing for their slight approximation to reality. But we really must bear in mind that it's not a costless thing, which means what value do we put on reducing inequalities, and what are we prepared to give up, especially in terms of efficiency, to reduce inequalities? And until we, in a sense, measure that value that we place on reducing inequalities, we're just stuck at this position, not knowing quite how much to invest in doing it. A lot of these inequalities you put up could be massively reduced to within insignificant statistical levels, but it will cost a lot of money. Yeah, just one other thing on the data issues. Those sort of S-shaped curves that you can, you plot health authorities or PCTs or CCGs or whatever it is, or hospitals, you get this shape of a curve. Just a plea for putting confidence intervals on all of those things. You can be a bit misled sometimes in thinking this variation is significant when it's not.
Andy.
Andy Cowper from HSJ and Health Policy Insight. Thanks for the 3 excellent presentations. If I understood the Secretary of State's speech yesterday correctly, he was saying that he's going to encourage more local variation, provided you don't do anything so mad as to vary the number of IVF cycles that people have. Could you just offer some practical thoughts for people in the room and beyond who are watching this being on the web about how you would go about resolving that tension in practical terms?
Okay, and Peter, and then we'll have some answers.
Thanks. The point I was going to make is from the perspective of a researcher who has often been criticised for not providing really good evidence on some of these. And I think, Louella, you showed that there are lots of sources of variation, that it's really difficult to know what the outcome is. And the lack of evidence does not mean there are no implications of the variation. It's just that the research hasn't been feasible. So what we really ought to be doing is learning from the variation. And so I wonder whether you see any scope for actually being more properly scientifically experimental about variation, and being able to provide evidence from this, from the sort of things that Rebecca has described, which actually are capable of being evaluated and which other people can learn from if they so wish, rather than having this constant refrain that there is no evidence that this is better or worse than some other approach.
Okay, let's, John, so the value we put on reducing variation. Any thoughts on that?
I agree. I think you can chase it down to the nth degree, but would it be your priority? And in one sense, that overlaps with how I would respond to Andy's question, which is, I think these are the decisions of local commissioners, taking your population health needs in the round. How far do you want to go on, delivering one type of service or not, and accepting the opportunity cost of another, or investing in reducing a variation, but then having an opportunity cost of that. And I can only sort of surmise from what we heard yesterday that there may be some interventions for which there will now be a national number, because they're high profile and create a lot of social media storm. But I hope it won't be everything. I hope there's going to be remain local discretion for the kinds of decisions that have been made in Greenwich that I told you about.
So one of my other research interests is in the issue of smaller and rural hospitals. And I think that this kind of issue of elimination of variation and how much do you spend really interesting. Because of course the studies have been showing that what everybody wants, no matter how rurally you live, is the Mayo Clinic at the end of your street. And there has become an expectation in the norm that actually a large quaternary hospital sitting locally for you, which is going to do everything for you all the time, is in fact the norm of care, when actually the norm of care in most countries, in most places, which actually get better healthcare outcomes than the UK, is a kind of a well-resourced DGH, which is there to take care of you with your chronic disease and your chronic comorbidities, and is interlinked into the general practice and actually provides you with holistic care. And in fact, the Death Star model of care is the exception rather than the norm. So I think there's this kind of interesting question around the issue of whether exceptional care should be the norm, or actually very, very good quality care, which I think is what most people want, is what's actually fair and more equitable and actually produces better results probably in the long run.
Okay. Pick up, Peter, your point, if I've understood it rightly. I mean, talking with Al Mully, who's one of the doyens of this whole area, going right back, working with Wenberg and others yesterday, we were reminding each other that the the reason that we spent so much time highlighting variations was a way of capturing politicians' and policy makers' attention to the fact that the status quo was probably not acceptable and was not the best of all possible worlds, even if we didn't know which end of a variation spectrum was the good end to be, the first step. Now, in some ways, that has been incredibly successful. It's also had the seeds of a real problem, because fairly early on, the politicians, I distinguish them from the policymakers in terms of, I think this morning was used wonks, but the civil servants, the informed people working on the data who got it. But a lot of the politicians immediately assumed that variation was a bad thing. Now, clearly, in that bottom left-hand quadrant of Nigel's graph, it is a bad thing. We want our hips cemented, we want antenatal steroids. But for the vast majority of healthcare, it doesn't lie in that quadrant. But that didn't stop the politicians thinking all variation is bad, we need to move everybody. Often it was actually bring in the extreme. The average was what was desirable, which is highly dubious. So in a sense, the research community, we were responsible for alerting the system. The system grabbed variation. The atlases were the sort of the greatest manifestation of that in some ways. So that was a success, but it's also some of the problems. But Peter, are you saying we ought to be making more use of variations for research through natural experiments and so on, and that perhaps we're not making as much use as we should be?
I think the point I'm making is that we need to be able to answer those politicians' questions, and either to say it really doesn't matter and actually it should be a matter for local thinking, or to say that it does matter and we should do something about it. But actually, what we tend to find, this is a slightly techie issue, but actually the areas that adopt one process are self-selected. So it's quite difficult to compare them with the areas that don't adopt that process, because there are all sorts of confounding things that mean that it might not be the process that's the reason for the different outcomes. There might be other reasons for that.
Yeah, so I'm very interested in this question because I'm actually trained my background is that I am a doctor, but I'm trained as an historian. And actually the whole entire point of history is that the context is never the same. So certain things will always be the same, but it's never directly applicable. And that actually in medicine, the constant pursuit of finding or comparisons between particular sites in which the context is never the same and therefore can never be the same, and therefore the lessons are only vaguely generalizable rather than universally applicable, is actually completely fine in history, but it's not actually fine in medicine. And there's this kind of interesting tension, I think, within health services research around the fact that the results of many studies are the same over and over again, which is if you had more time, you had more money, you had better leadership skills and people got along, actually everything would go much better. But the question is, how do you do that? And every single airport bookshop is full of a whole entire wall full of books, which are constantly changing, which tells me how I ought to do that. And so I think that there's something in this about where we run up against complexity, against human nature, and the mystery of being human. And I quite like that because I'm a historian by background, but I think it creates interesting problems with it. And to a certain extent, I think that we would just have to say there are certain things that are unknowable, and we have to be comfortable with that. And actually, we have to look at the outcomes rather than sometimes being quite so obsessed by the process and being able to replicate process, because it's never the same. It's always contextually constrained.
Yeah. I think the covers of the books are changing. I'm not sure the contents. There's somebody over here. There's somebody with them. Al here and here. And then we'll come to the other hands after that. Let's take those three. Yes.
Can you hear me? Is it on?
Yes.
Yeah, okay. So I'm Anita Donnelly. I'm the ex-chair for 3.5 years of the Mid and South Essex STP. And my question is a lava lamp related one. So we seem to have replaced what used to be the obsession between strategic health authorities, then every 7 years the lava lamp size would change, the bubble would then go down to regional health authority or whatever. We seem now to have replaced that with something at system versus place level. And my question is this. The panel have made a very, very strong and entirely impassioned and correct presentation based around identifying local population need. At what point do they think it is reasonable to retrofit a system-level evaluation framework, trying to reconcile some of the Health and Wellbeing Board strategies on a 5-year horizon, council plans that often on a 30-year horizon for populations, to establish something which is an evaluation framework that will enable system leaders at ICS level to begin to contemplate their SOS strategy. And the SOS is for system oversight and scrutiny, coming soon to an ICS near you. I'm sorry it's quite a long-winded question, but I think it's quite interesting how we started off saying system would bind all these things together in some glorious world. And now we're talking, again, in much more detail, much more granularity, and much more reality about things that happen at place level.
Okay. Where were we? Yes.
Hi, Catherine Scott from the British Psychological Society. My question's about workforce again. And I think we've been working advising on the people plan. And one of the things that is kind of replicated at that level is in terms of the people plan is going to set at a national level certain standard things. So a leadership compact, which will be dictated from central and dictate is possibly the wrong word, but shared from that level down, and it's up to the individual organisations to adopt it themselves. Similar thing with a kind of well-being offer for staff, for NHS staff. And that, again, there's going to be variation in the way that those things are adopted and rolled out and implemented across the NHS. And again, it does play into patient experience, because happy staff, happy patients, essentially. And I think that's another question, like how much variation are we willing to accept in terms of how staff are supported, treated, services that are there for them. And so I think that's part of my question. And then the other part on workforce is a little bit about, so thinking about psychological services particularly, the nature of what we can deliver is dictated to some extent by the makeup of the multidisciplinary team that is delivering that. So thinking about what kind of workforce models might be, set at different levels and how that might impact on outcomes is another question.
Okay. Al?
I'm afraid this falls into the category of Alastair Campbell's concern about when your board's saying something, people may just begin to be listening, that Nigel made yesterday. And I want to make three general points that relate to the conversation between you and Steve, Nick, and then talk a little bit about context, and I'll do it quickly. I think if you're trying to engage a PCN or at an ICS level, people in thinking about how to learn from variation, you can start with some questions. You can start with, is variation seen as a source of learning in your locality or in your organization, or does it elicit fear of judgment? In 2000, I was asked by Richard Smith to write an editorial in response to publication of the first league tables, and it was titled, Use Variation for Learning, Not Judgment. We learn from variation in outcomes and costs by making visible underlying processes. We learn from variation in per capita rates by making visible underlying professional consensus or individual preferences. The second point is the question is the distinction between warranted and unwarranted variation understood and respected in your organization or your locality? That was a distinction made in 1980, and it was meant to distinguish between a decision that was sensitive to evidence, probabilities of different outcomes, and decisions that were far more sensitive to what the economists would call the utility or disutility of the outcome for the individual. and its timing and the associated risks in the decision. The third is context respected at the level of the system and the level of the individual? What is it that shapes preferences for an individual? It's the context in which they were born into, aged, formed, and all of the experience they've had in the process. We talk an awful lot about ACEs now. That's a context for an individual. And it shapes the way they see the world in many ways, and we're trying to figure out how to respond to that. So the point I'm trying to make here generally is I don't see necessary trade-offs between learning from variation and addressing inequity. In fact, I think it is the key. It's the people who are dealing with deprivation who we need to learn most from by trying to understand the context in which they live their life and the way that's shaped their preferences and what matters to them.
Okay. The issues raised vis-a-vis a sort of ICS perspective and strategic.
Yeah, I was trying to think how to answer that. I mean, it's so difficult because in one sense, the strategic vision should be translatable down to a local level and then implemented in an appropriate way at place level. But their context is all. And I think one of the things I have found most bemusing in the clinical side of my existence is when a plan is given to me that makes the assumption that I can go from our current performance of, on the 25th centile up to the 80th centile. Major financial models are built on the savings that are going to be made, and nobody takes account of whatever context it is in my own local patch that is going to help or hinder that. And I think that's where we need to get more thoughtful about how we translate the ICS type plans that are now emerging and really think of them down at place-based level. And we have an assumption. I'm in South East London. We have 6 boroughs. We've got a percentage of shift in outpatients that we are meant to achieve. And actually, probably that does need to be nuanced at local level, disentangled, some real thought given to it, but we've never proved ourselves. In the last few years, we just have this where you're going to make a 60% increase in the next 11 months, and we're going to take 45 million out of the system. And I think that's where we need to challenge ourselves. I guess I don't know if that properly answers your question about the interplay between the two, but I think we should push ourselves further on the assumptions and expectations that we come up with.
What about the workforce issues raised? Do you want to pick up that one?
Yeah, so I think this is really quite interesting because when we talk about workforce and the nature of work, there are several sets of factors which operate at various layers. And one of the big problems with the NHS is absolutely terrible at workforce hygiene. So the basic notion about signing up to the organisation, is that smooth and easy? Do you feel valued when you get there? On the day that you arrive, particularly if you're something like a junior doctor and nursing staff, do you know where you're meant to be? Do you have a badge? Are they going to pay you? Because frequently they don't. I know of doctors who take 6 months to be paid for the first time. What about your car parking? So all of, do you have an office space? Does your kit work? Are you raging in frustration because nothing in the organisation is where it's supposed to be? So the NHS has this kind of layer of frustration that's almost built into kind of the nature of all workforce. And I think that some of the things that are discussed in this, it's not labelled as hygiene, it's labelled as workforce in the offer. But that's really what they're talking about. They're talking about the basic nature of what it is to go to work and what is your environment like. I then think there's the really interesting issue of all work in the NHS, in fact, in many medical settings, is very heavily siloed around professional discipline, which comes back to issues around regulation, which in many ways is perfectly appropriate. But in a situation where you have a workforce crisis, then proper interdisciplinary working is critical. So actually breaking down some of those problems across disciplines and actually beginning to work together in better ways is enormously problematic. And the research around this suggests that when it is done well, it's transformational, but it's not done very well in very many places because it's really difficult to do. And it takes money and it takes time and it takes shared space, shared goals, shared vision, leadership, all the things that we've discussed that are much easier to talk about than they are to ever actually enact. And then I think there's the really interesting issue of a lot of services actually dependent on getting the right person into the service at the right time. Now, your whole entire service can't depend on Jan being there every day because, you know, some days Jan's going to be off sick and at some point Jan's going to retire. So you can't build your whole entire service around that. But actually using people's strengths and interrelationships much better. And you know, we've been to a hospital down in the south of London where actually all of the doctors all work in teams of pods. So people are kind of divided up around their strengths and their interests, and then they're paired with people from other pods. And some of those pairings are dynamic and some of them are set. But actually in this way, you get more out of 2 doctors than you would out of 2 doctors. You get something that's dynamic and is much better for the patients. And I think we need to be really smarter about thinking about that kind of thing. But of course, again, that comes back to this issue. It's easy to talk about it at national level, but it's much harder to deliver at local level. Because we don't really, you know, at the moment, it's not yet fully understood and it's only partially articulated. But focus on hygiene to start off with, and then how do we actually better use each member of our workforce given what a valuable resource they are, I think is a really interesting question.
Okay. Al, picking up your point, if I sort of try and combine the 3 bits together, it seems to be the common thing, as I understood from what you were saying, is in a sense is when information on variation lands on policymakers, managers, STP chairs' desks, what are they meant to do with it? What happens? And I think you're right. There is probably insufficient understanding of the concepts of warranted and unwarranted variation, insufficient realization about. Now, actually, I was going to say insufficient realization of context, but actually I suspect the managers are very well aware of context. But it's bringing it all together, and that comes to point, what is the point of all this variation work that we can do? The data's there's more and more of it. And that seems to me to be, it was what it was always about, but we need to perhaps readjust. It's a trigger, it's a disruptor to get people to think, why are we doing it that way? Because most people, individual clinicians, all believe the way they do something is the way all their colleagues do it because they don't see what they're doing. It's understandable. Everybody thinks the way they're doing it is the way everybody does it, every walk of life. So that if nothing else, it acts to disrupt and think, oh my God, we're here on this spectrum of things. Other people do things in different ways, and it may be the workforce use, all sorts of things. It may be the costs. It could be all sorts of stuff. And that is simply the trigger for the debate when the real issues start being addressed as to why, and are we comfortable with that? Yes, carry on. Or let's change things. I can see you're dying to come back in. I'll let you come back in and then we'll take very quickly. There's one more question up here.
Just very quickly, where those 3 points point, where those 3 observations point is to measuring the quality of decisions that are made. When there's susceptibility to warranted variation, when the decision depends upon knowing what trade-offs somebody is willing to make or not, measure the quality of the decision. Every high-quality decision, if you measure it and you can designate it as such, then gives you the critical information that commissioners need and don't have.
Yep.
Which is, what is it that people want and need when they understand the trade-offs?
Becky, answer while you get the mic to the last
One very
person.
quick observation on that. I think one of the difficulties is that what gets counted as warranted and unwarranted variation can sometimes fail to take account of context. So, you know, the GERFT initiative around high-volume cataracts, you'd think it's a no-brainer. Yes, of course, why isn't everybody doing 8 cataracts or 10 cataracts on a list? But in some areas, it turns out, all the simple cataracts are being done in shop fronts somewhere or GP surgeries by entrepreneurial GPs, and the ones left in the hospital are really, really hard to do, and you can't actually do 6 in a list or 8 in a list. And so that narrative that we have about warranted and unwarranted has to go back to context. So it's a, yeah.
Okay, last question, comment.
Thank you. Well, two things, and I think that we haven't really picked up in this debate, but I think reflect very much back to Rebecca's very original observations in the presentation. There's a difference, and there's definitely a difference in the public mind and the way they discuss this, and we've explored this a lot with people, between variation and the flaw. So, I mean, in your patch, you've still got 1 in 10 people are over the age of 65. It's less than your neighbours, but still a good chunk of the population. Can they get a home visit or not? That's the flaw. So I think people accept that, for example, there may not be the resources put into it that there might be into your neighbours because there's a difference in the sort of nature of the population, and that's fine. But there should be a flaw to that, and actually it shouldn't be the case that anybody in your patch can't get one when they need one. So I think we need to differentiate a little bit between variation, what's the variation and how warranted or unwarranted might that be, but what is the absolute minimum that people expect and should expect. And I guess then that feeds through into a second thing, which again you picked up, but we haven't really explored. And it's certainly, I think I've got a lot of anxiety around it, around the population health management approaches, is that data doesn't answer questions we don't ask. If we don't collect data and then we don't ask the questions of it, and what we collect and what questions we ask absolutely reflect our own biases, then it doesn't answer those questions, and therefore we don't know. And I mean, just to pick a really quick example of this, there was a long sense of a view that, despite all the anecdotal evidence, et cetera, that older people pretty much had a good experience in hospital. Because when we looked at patient experience data for the over 65s, it was better than everyone else. And you thought, well, that can't be true. And it was actually only relatively recently people that actually interested enough to go and ask that question. Of course, lo and behold, what you find is that no, younger older people in their 60s and 70s with less complex conditions are responding, and they do have a better experience. Older people with disabilities, frailties, dementia are actually having quite a poor experience. But we never knew that because we never asked that question. So I think we have to, and that's my anxiety, that are we missing out big groups of people here because we just don't ask?
Okay. We're going to take that as a comment on it rather than a question, partly because I must hand over to Nigel to close the summit. Nigel.
Thanks. Thank you, Nick, for pulling together a very interesting session. So we've come to the end. And what we normally do at this point is try and pull out what the themes. There's quite a lot to take away, isn't there? We've talked a lot about variation over different sessions. We've talked about the importance of generalism quite a few times, the legitimacy of some of our decision processes, the groups who've been neglected. But I've just thought, did this last year, invite anyone to just sort of say, what's one thing they might take away that they've learned, surprised them? They might have learned it from someone on the stage, or they might have learned it over a conversation over coffee. But anyone like to give me a thought on that? We have a microphone again circulating. Yeah, right at the law of microphone handling says that the person furthest from the microphone puts their hand up. So, yeah, thank you.
Hi, thanks. Well, it's been a great summit. It's been my first one. And I think what I've learned is that I need to know more about policy, because for me there's still a bit of a disconnect between what's happening at policy and what I'm trying to do on the ground. So I think I need to know about it, and I want to bridge that gap.
Although you might remember what Bismarck said, that no one who is interested in policy should ever, it's like sausages, you should never watch it being made. But thank you for that. That's a great observation. Anyone else got something that I can't really see? Masood is there. Also now furthest from the microphone again on behalf of the operation. Good.
I was surprised about international comparison and USA data, because at aggregated levels, we have got one vision about US healthcare, but when actually you break it down, it's completely different, and that really took me by surprise.
Yeah. Everything is slightly more complicated than you think in almost every field, isn't it? Anyone else got any other thoughts? Yes, as Sean, I think, yeah.
Thank you for a great summit, Nigel. I was struck by, first of all, Chris Whitty's fantastic speech, and particularly his stats on outpatients, and that it's not all about old people, which really landed with me. And then also, just as an aside, the Louella mentioned the streaming and no evidence for streaming when GPs in emergency care. And I think that touched a theme for me, which I've heard over the 2 days around some of the decisions and policies being imposed from above, which people seem to be questioning in this room. And I just wonder how that translates outside this room in everyday practice. And that maybe I'm bringing my own bias there, but towards the regulators. But I just found that that's a theme I've heard lots of people mentioning.
Yeah, great. Can I ask you to fill in your evaluation forms now? And we'll take another comment from Eileen while you're doing that, but we'd like you to complete them. They're very important to us. So we'll go to Eileen, and then we'll come to Richard. But if you could do your forms while we take those comments, we'd be very grateful. Eileen.
So 2 things. I think the first speaker this morning needs to send his slides to the people who are going to be doing the trade negotiations with our American colleagues, because I don't know if people were struck when there was all the furore about America's going to take over our NHS, which was nonsense, but there definitely was the American ambassador saying, why do our American patients pay so much for their drugs and you guys in Europe get them so cheaply? And no sense of the Americans should be paying less, a sense that we should be paying more. So I think we need to get him to send his slides to the Brexit negotiators, or the American negotiators. And the second thing is, it is all about old people. It's not only about old people, but it's especially about old people with dementia. And we haven't talked about that at all here, but services for that group from health and social care are poor and are causing huge numbers of people to default into hospital and get stuck there. So whilst everything else we've talked about is really important, we mustn't get a bit bored and think, oh, we've talked a bit about old people and now it's time to move on. It's still really important.
Great, thank you. I'm noticing some of you not doing your evaluation forms. I'm trusting that you've done them already, so no pressure. Richard, shall we come to you? There's Richard here, and then we'll move on.
So I'm sorry, I was struck by the sort of the consistency of the message from the representatives of the government whom we had speak to us, compared to the diversity and complexity and nuance of the conversation coming from people who are actually doing the work. And I suppose I always knew that was the case, but I hadn't had it quite so consistently displayed to me in such a short period of time that I could notice it. And I'm still backing the people who are doing the work.
Thank you. Thanks for that. History has been one of the themes of the. It's kept coming up, hasn't it? Which is interesting. On your tables, we've got a little description of what we think our strategy is. It's quite a quick and good read, which will tell you a little bit about what we're doing. And we focused a lot on. We're really focused on things which we think are really important but not sufficiently studied, and where you think there's something important to say. It turns out that some things which are important, not studied, that there's limited things you can get your teeth into. But one of the reasons why we looked at prisons, because it fits that category. Children, young people, actually, we think are still in that in that category. Workforce, of course, and social care, but also history. We've taken over. Some of you might be familiar with Geoffrey Rivette, who wrote a history of the NHS for the King's Fund, and then kept it up to date for the next 20 years on a homemade website that he's created, which we're now taking over. It's called nhshistory.net, and it's going to be on the Nuffield Trust website. And we're hoping to build more history resources. We're going to be working with the Health Foundation, I hope, to bring together some of the academics who work in this area, but to try and fill some of the gap in the NHS's very poor historical memory, so that we can use history as a policy analysis tool, as well as recording that. We're also working with the European Observatory on Health Systems and Policies to provide us and with the Health Foundation on getting a better documentation of what is happening at the time. But of course, it's always important to go back and study that. So we'll be launching this fairly shortly, and it's been moved from this 1990s website with radio buttons to something a little bit slicker. It works by decade. So it has a chronology, and it's pretty searchable. It's missing a few thematic things that we want to try and see if we can fill the gaps on. So we'll be working working to do that. I hope you've enjoyed the summit. I think it's been fantastically interesting. If you're interested in working with us or coming to the occasional small seminar that we run, do get in touch and tell us. If any of you have got an idea about what we should call this event, I'd be really grateful. When it was first set up, before I joined the Trust, it had much more of a feel about sort of getting the sort of top officials from NHS and Department of Health to come and talk at people. And we've moved it, you may have noticed, to something that's more like a really interesting and quite eclectic group of people who represent all sorts of different interests and points of view. So it's not really a summit in that sense, it's more of a salon. But that doesn't sound right either. If you remember those 18th century salons, they were run by women. This one's run by women. And it brings together interesting people, but it doesn't quite have the same. Symposium sounds a bit pretentious. Colloquium, even more so. Agora, they have in Europe for this sort of thing. In the EU, they call this an agora, marketplace. But if you have any ideas about what we might call it, because it might be sensible. The summit sets up a slightly different expectation, but maybe then we can actually meet, and maybe doesn't quite reflect the nature of the event. A final thanks to our partners, Optum, MSD, and our media partner, BMJ, I said last night, excellent to work with. And a particular thanks to our AV team, the conference organising team, and indeed to the hotel staff, who I think you'll agree have all done a fantastic job, despite the competition for the frequency that we're using on the radio mic. Apparently somebody else is illegally using it, so that's why we've had this cutting out, which is a shame. But I think you'll agree they've done a great job with the logistics and putting together a fantastic event. At least I've enjoyed it. I am now going to go home and lie down, and I suggest you all think about doing the same. Lunch will be served next door, and we hope to see you next year. Thank you very much.